All right, so today we're going to review a study that was published late in 2024. Looks like it went online live in November 2024 in a very esteemed journal, the North American Spine Society Journal. The topic of this study is healthcare utilization among Medicare beneficiaries with newly diagnosed back pain. So a couple of things I'm going to notice off the bat. This was done at Stanford, so obviously a very reputable source from the Department of Neurosurgery, and also looks like a database unit called the Quantitative Sciences Unit in Stanford. And so what we're going to do is we're going to go through basically my live reaction of the study, just reviewing it and kind of digesting it, what it means for the Medicare population, which of course would be applicable to health plans that do Medicare Advantage, ACOs, and the government that manage Medicare fee-for-service. So let's dive right in. So they're focusing on people with low back pain. This is the most common cause of disability in people over 65. So again, it's again driving home the fact that MSK and spine conditions are really, really high. What we're going to do is in this study, they're going to look at new diagnoses of low back pain, and they're going to look at a couple things. One is they're going to look at costs between operative and non-operative. And then we're going to identify those patients based on ICD codes, which they talk about here. And those are those diagnosis codes that they look at claims and they find out which ones have back pain associated with them. What they did was they excluded, I'll write that down here, anyone with a red flag sign or neurological deficit or neurological deficit here that definitely needed surgery. So it really was making an apples to apples of people that actually could be managed non-operatively or those who had surgery that were elective. So again, removing all the non-elective conditions like these red flag signs and neurological deficits. And what they also looked at was guideline adherence, especially with different treatment modalities for non-operative care. And this is just the summary, the abstract, but a couple things to point out. What they found was about 1.8 underwent surgery, and this drove what it looks like here is 7% of costs, which is not surprising, right? The surgical ones are going to be more expensive. A couple things that really caught my mind. The non-operative managed patients, check this out here. It was $6,000 per person. So think about, as a health plan, you're always worried about the back surgeries, right? All this utilization management around spine surgeries. The Medicare beneficiaries that are undergoing non-operative care, right? Physical therapy, injections, all that stuff, imaging, MRIs, are driving up $6,000 in this episode, which I think it was on a yearly basis, but I could be wrong. And the other thing is the guideline non-adherence. So people that were not following the guidelines, not that the patients were not following the guidelines, but that their treatment didn't follow the guidelines. So doctors prescribing too many MRIs, injections, procedures. This increased cost by $4,000 per person. And what you'll see here is if they were non-adherent, $7,800, and if they're adherent, $3,800. So when we start doing, this is that unnecessary overutilization of care. This is $4,000 of extra costs for non-adherence, and this is in the non-operative population. So what we'll do is we'll keep moving forward, and there's some stuff on opioids, which we'll dive into in a second. So let's look at the conclusion statement, because I like looking at the conclusion statement before I read the rest of the study so I know what the main point is of the study that the authors are trying to signify. And what they've called out is obviously non-operative management is associated with lower costs than surgery for low back pain. That's fairly obvious. But here is the kicker, and this is what we know. Imaging and opioid use are the drivers of excess costs. So when you are thinking about cost control, and again, this is unnecessary costs, by the way. When you're thinking about cost control, you need to focus on imaging reduction and opioid reduction, right? That is what's going to drive your major cost savings without any adverse patient effects, of course, because these are all unnecessary costs. Okay, so let's get into the heart of the study. So this is the introduction, typically where the authors will kind of paint the picture about why are they doing the study. The big take home here is that what they're saying is that low back pain can have a prevalence in older adults of 85%, which is not surprising, but it just shows how important this problem is. In the Medicare population, when we talk to risk-bearing providers, a lot of times the focus is on those big conditions of heart failure, renal disease, lung COPD, other lung issues, and MSK is not considered sometimes that top cost driver. But the thing is that when you think of modifiable cost drivers, like what can we actually do to lower costs? It's very hard to prevent unnecessary cancers, right? Like you're going to spend the money on cancer, and you can maybe tweak a little bit on appropriateness, which I'm sure there is an opportunity. But MSK is the issue where we're doing too many surgeries, doing too many MRIs, which are leading to surgeries, and we can really change behavior if we start focusing on better non-operative care. So 85% of the population, which is huge for low back pain. And again, the theme we're going to keep saying here is that they point to a study in comparison of 2 million patients. And what they're saying is that the two drivers of costs are surgeries, which we know is obvious, but here again, what goes hand in hand is early imaging. When we get an x-ray of somebody with back pain, especially in that Medicare population, you're going to find findings, right? Facet arthropathy, some stenosis, or canal narrowing, whatever it is, some mild stuff, degenerative joint disease, disc disease, whatever it is. Well, if you're a primary care doctor, you don't know what to do those findings. And so you send them to a specialist, and then you're going to end up with an injection. Those don't work. And people aren't taught that it's okay to have some pain, right? And they can live with pain, they can work around with it, but they have pain, so they're convinced to have these spinal fusions, right? And so that's what's driving this. That's why you're going to keep seeing early imaging drives surgery. So you've got to get people out of getting unnecessary x-rays and MRIs, and that's your key to saving. The other part of the study is where they set up the purpose. What they're saying here is, to our knowledge, this is the first study to characterize healthcare costs and treatment patterns of newly diagnosed low back pain, right? So they're looking at people who just got their first diagnosis of low back pain. It's Medicare data, so it's pretty reliable. It's like the single payer, right, of Medicare, so they have it. So there's not a lot of in and out like you will with a commercial plan. And they're trying to understand what is driving the costs of care for these new back pain patients. And what they're also doing is, in addition to looking at the operative versus non-operative costs, what they're trying to do is calculate the costs associated with non-adherence in non-operative management of back pain. This is huge, right? This is what we can save. This is what we can reduce without any, I would argue actually, with improving quality by reducing these sorts of imaging and surgeries that are unnecessary. So let's keep going to the study. Now, this is looking at a de-identified data set from a 20% sample of Medicare individuals, which is a pretty typical methodology in these types of studies. They're looking at different types of cost drivers here, and reviewed by the IRB at Stanford, and just kind of some more details on medication. So I'm going to kind of gloss over a little bit on the methodology, just on the nuances of the patient selection, because at the end of the day, they outline it here. If you want to know more, you can look up the study, but let's really kind of dive into what the authors found. What I like about the study, this is a very high quality journal and clearly a very experienced research team, is that they call out the primary outcomes here, right? And if we look at the primary outcomes, what they're looking at is total cost, first year after diagnosis. Okay, sorry, handwriting hopefully is legible there, but they're looking at the total cost after the first year of diagnosis, and they're looking at did they get surgery, what the conservative management was, x-rays, imaging, injections, PT, so forth, and what those types of services were, as I mentioned. So they also adjusted these costs for inflation to make them relevant for today, and then they classified folks into the surgical versus non-surgical cohorts. Okay, so those are your two groups, and they're looking at different breakdowns of costs. The other thing is that the study authors said that they're going to look at the cost of non-adherence, and the question is, how do they know if something was non-adherent from a recommendation perspective for treatment? Well, here's what they did. So what they looked at was they explored the potential economic impact of deviation of guidelines for those who did not need surgery. Now, remember what we said earlier, they excluded all the people with red flag signs, progressive neurological weakness, cancers, traumas, all that stuff that needed surgery. So this is an elective group of patients. And so what they said was this, they looked at two guidelines, right? What they said was imaging should not be obtained within 30 days of diagnosis. So if you wake up with back pain and you have not done any non-operative treatment, physical therapy, rest, activity modification, anti-inflammatory medications, or anything, and you don't have any red flag signs, you should not get imaging that first 30 days. And of course, that's probably not what we do in real life, right? We know that. And then imaging, number two, imaging should not be obtained without a trial of physical therapy. So again, just what I said, you shouldn't get imaging within 30 days, and you shouldn't get imaging unless you've tried an exercise program, right? So first line of treatment is that rest, activity modification, anti-inflammatory pain medication when allowable, and a trial of physical therapy. So if you're not getting imaging and you're not doing those two things, that means you're violating those best practices or guidelines. So again, not the patient, but the system and the prescriber or the provider. The other thing is that we talked about opioid use. And so what the authors did was, if you look over here, we assessed the frequency, amount, and cost of opioids prescribed in the setting of new onset low back pain. As published guidelines and trials note that opioids should not be prescribed unless other modalities are ineffective. So again, early in that disease course for low back pain, there really is no reason to get opioids on board. And I think that, this data looked at, I think it was a couple of years before the publication, they looked at data. I will say with the opioid sensitivity, these numbers are going to be getting better and better. But we certainly see a lot of folks in our office who have early onset, back pain, shoulder pain, knee pain, and somebody gave them a tramadol prescription. Could be in the urgent care, could be primary care, could be specialist, who knows? But that is a huge no-no unless there's a really compelling reason to give them some sort of narcotic pain medicine. And then finally, they looked at some of the interventions that people were getting, and they looked at folks who were getting steroid injections, imaging, PT, and they looked at those costs compared to surgical versus non-surgical. All right, so I've skipped down a little bit. We're now in the results section. A couple things to highlight. This is a big study, 1.3 million individuals. And what we found was that, 98% no surgery, about 2% had surgery. Okay, so we saw that that's about the breakdown. So when I talk to health plans, sometimes they ask me, well, how do we know what our benchmark is? And so this is one way to look at it. Of your new diagnosis, low back pain without red flags. Now it's a little bit of work to tease that out based on diagnosis. But when you do that, you'll say that the benchmark is about 2% should have surgery. And I'm not saying this is proper. We might be over operating, of course, but in the national benchmarks, about 2% are getting surgery. Again, this is a Medicare population, so those that got surgery are about a year and a half age difference, 68.8 versus 67.4, so maybe a little bit older. It was statistically significant, but when you're at this size of population, it's not surprising. And women, female patients, about 56%, so close to evenly distributed. As we go down, so expenditures attributable to patients treated non-operatively, the majority, which is 98%, accounted for 94% of the total 12-month spending. So, or 93.4%. So what we're saying is that, again, we focus on surgeries, but it's really the whole population that's driving the cost. You've got 98% of the population not having surgery. You should probably focus on those too. And guess what the drivers are? Getting that early imaging lower. So this is a pretty telling that, if we said that 2% of the surgical patients were driving 70% of the costs, 80% of the costs, then you should focus on the surgical patients. And if you look at utilization management now, we focus on the surgical ones, but what about all those that are driving costs? And your best entry point is don't let them get that X-ray or MRI unless they absolutely have to. And you can do it from a utilization perspective, utilization management perspective, but that makes people really angry. It's best to treat them upstream and just get them better through different care models and delivery models that are multidisciplinary and actually treat the problem rather than getting down this cascade of excess costs. Okay, so let's dive into some of these really interesting results. So there were, if they look at this first data point, there were 33.7% of patients that got no PT, imaging, or injection. And they drove 17.7% of the cost. They basically had the diagnosis, but they didn't get any treatments, any major of those treatments in those categories. They didn't get any PT, imaging, or injections, and they drove proportionally less amount of the costs. Now, let's look at this group here. The ones that received imaging only, 39.7% imaging only. Okay, no PT, injection, just imaging alone. And they accounted for 49.2% of the costs. So they did not get physical therapy, and they were responsible for proportionally higher amounts of the cost. And then finally, The ones that got either PT alone or PT plus imaging, they're about 11 to 12%. PT plus or minus imaging, they drove 7% of the costs. So what that tells me is that when you get physical therapy on board, you can actually lower costs of care. And so this whole thing about charging patients copays and deductibles for their physical therapy, all you're doing is you're just driving up your costs, because the ones who are getting the imaging with no PT, this group here, they are driving up the cost. So the more you gatekeep physical therapy and exercise therapy, the more you have a chance of having people route down this path of high expense care. And again, these are for the non-surgical patients. All right, and so when we look at it all in kind of perspective, when we compare the non-surgical patients to the surgical patients, what we find is that the difference was about $20,000, $22,000 of difference in the ones who had surgery versus non-surgery. Over here, one thing to call out, 53% of the folks in the surgical cohort did not receive physical therapy or injections. Their average cost was $27,000. So what's kind of amazing is that these folks just went in right to surgery without doing any sort of therapy at all. And so I it's hard to judge exactly why. We know they didn't have a red flag sign. One thing that's really impressive is that when you look at the surgical cohort, 53% did not get any physical therapy or injections. They went right to surgery. Now, it's hard to tell exactly why they were indicated for those surgeries by the surgeons, but it's pretty eye-opening that 53% of those who had surgery did not even do any exercise or any formal exercise therapy whatsoever. And I think that's the indictment of the system that we're in, that we have this bias towards surgery. And their costs were about $27,000. So a very, very high cost per patient. So let's move on a little bit more and talk about kind of guideline non-adherence. When we're looking at guideline non-adherence, again, they had those rules about getting imaging in the first 30 days and imaging without doing any sort of physical therapy. So in the non-surgical cohort, 50% appear to be non-adherent to imaging guidelines for conservative management, meaning that 50% got imaging when they weren't supposed to. They tend to be a little bit older by a couple of years, 68 or maybe a year and change, 68 to 66.7 years old, and had a slightly higher comorbidity burden, meaning they were a little bit sicker, a little more of comorbidities and medical conditions. So a little bit of skew there, but again, 50% getting imaging when they should not have, and I think that's the main take home there. And what they said here, about 31% of the non-surgical cohort underwent imaging within 30 days of diagnosis, while almost 50% had imaging before a trial of physical therapy. Now, if you think about it, you go to your primary care office and you say you got back pain. We have guidelines on when to get imaging, as we discussed, and too many people are just getting imaging off the bat, and that's what's driving this non-adherence. The other eye-opening thing is that this non-adherence to imaging, what was it responsible for? Responsible for increase of $4,538 of spend. So by not following the guidelines, you had $4,500 of extra expenditures for those same non-operative patients. Now let's look at opioids. Here's the finding here. Again, with the entire study cohort, 24% of patients had opioid prescription within 30 days of their low back pain diagnosis. This is really bad, right? Like, opioids should never be a frontline treatment this early, and maybe in a few people, but not for these new diagnoses. So I'm going to go out and say right there that is way, way too much. And that is just poor education to our patients and poor guideline following by our providers. And that's just, there's no way to look at that otherwise. I could be wrong, but that's at least my interpretation for it. Patients in the non-surgical cohort that were not adherent to imaging guidelines were more likely to have an opioid prescription, 26% of adherence versus 21%. So about a 5% increase in opioid, misspelling there, opioid increase if they're non-adherent. Okay. Again, this is going that same rule. If they're not following the guidelines, they're getting more opioids, they're getting more imaging, they're getting more surgery, and they're driving more costs. And quantifying that increase, it says being prescribed any opioid medication within 30 days of diagnosis was associated with a $1,000 increase in annual costs. So right there again, that impact of costs driving. So I think the take home here that we have is that when you look at the summary findings, you're looking at a basically what we said, over a $20,000 difference in surgery versus no surgery. And the key that we have to deal with, so I'll put it over here. So greater than $20,000 difference, surgery versus no surgery in low back pain. The problems that we need to contend with is early, inappropriate imaging and opioid use. And then lack of PT in the early diagnosis phase. So if you're a health plan leader and you say, okay, I want to cut this problem down, what is the solution? Okay, so we want to think, okay, what's the solution if you're an ACO leader or a health plan leader? Is invest in early PT and exercise programs, okay? And then also we saw that the problem areas were ones that the problem issues were ones that were patients were a little older and a little sicker. So then you want to do multidisciplinary programs and then heavy focus on patient education, right? Making sure they understand that you should not be getting early imaging, early medications, and also on provider education. So hope this was helpful. These are some key takeaways from my end, a lot of insights, and looking forward to sharing more articles that are eye-opening like this on how we can actually take actionable change to lowering these healthcare costs for our patients.